What's up, everybody? My name is Cricket Smith, and we are here at Show and Tell Boston, where we facilitate tough conversations that no one wants to have. I have my friend Tata to the left of me. Tata, say what's up.
What's up?
Today's conversation is going to be about sexual health and STDs. We have our friends here from Mass Seal and Boston Medical Center. I'm going to start with Shakira to my right, your left. Shakira, can you start by introducing yourself and your role within the team, and then we'll take it to the other.
Hello, everyone. My name is Shakira Robinson. I am a community engagement specialist here at the Massachusetts Community Engagement Alliance at BMC, and my role is to help facilitate and foster meaningful relationships with community members and community-based organizations such as Show and Tell Boston to help leverage our efforts in addressing public health disparities in BIPOC communities and abroad, and we're happy to be here.
Thank you.
Hi, I'm Cassandra Pierre. I am an infectious disease doctor at Boston Medical Center. I'm also privileged to work with Shakira on the Mass Seal team. My job is to see patients living with infectious diseases, including HIV, STDs, and also come up with policies that protect our patients and our healthcare workers from infections.
And my name is Justin Alves. I'm a nurse practitioner for Boston Medical Center. I'm also the co-medical director of the Stimulant Treatment and Recovery Team, so I run the crack cocaine and crystal meth clinic. And I have a primary care practice that serves mostly queer folks and folks with HIV. So I do a lot of STD treatment, a lot of STI testing, and then I'm in family medicine, so I see people throughout the continuum of life. So you can get pregnant and come see me. I do your prenatal care and get you to pregnancy, to delivery, the whole bit. So
That's amazing.
Can I ask you guys, what is the popular conversations happening around the clinics and where you guys are at? What's going on that we should know about sexual health and everything about that?
I mean, what I will say is I think we're lucky in Massachusetts. We have a lot of access to stuff, but we know that things are still on the rise. So we still are seeing this rise in STIs. We're still seeing this rise in HIV, particularly in the city of Boston. And so really figuring out how do we get the services people need to the people who need them most. I mean, I think that's what I spend a lot of my time thinking about. I think Cassandra and Shakira spend a lot of their time thinking about that. But
Yeah, no, I agree with you. I also do clinical. Oh, sorry. Thanks. I also do clinical care for people living with HIV and also HIV in pregnancy. And I'm always surprised to hear about what people know and don't know. For example, one of the STIs that Justin is mentioning is syphilis, and we're seeing an explosion of syphilis in our community, including pregnant women. And so, there's a concern there for our women and then also for their babies, because syphilis can be transmitted to an unborn fetus, to the baby. So we're seeing a lot of congenital syphilis that's transmitted to the babies. And I think, the conversations that we're having is just basic conversations about what these diseases are, how we treat them. And then in terms of the access issue, because we have had access issues, pregnancy is one of the few times that people can get dedicated health care, both in terms of insurance coverage and then in terms of this is care that you have to get prepared for the birth. And so we kind of see an accumulation of a lifetime of unmet health needs. So I just want to second that as well. So that's part of the conversations that we're hearing.
So starting off with that, with syphilis, what is making syphilis such an explosive thing that we're seeing right now? And what is it that, are you seeing that people aren't being they're not knowing the symptoms of it, or what is going on with syphilis? And actually, what is syphilis? How do you realize that?
Yeah, great question. So syphilis is a bacterial infection that causes a sexually transmitted disease, but it's not just a sexually transmitted disease, right? It's not just something that's going to affect our sexual health. It goes way beyond that. There are different stages of syphilis. So usually when we think about syphilis, we think about a sore on the penis, on the vagina. We think about getting a rash on the body. But if left untreated, people can have really severe outcomes. Like I mentioned, it can cause issues with babies and can cause developmental issues with babies. For people who are untreated, it can cause problems with your heart. It can cause problems with cognition, dementia, and with your eyes, your eyesight itself. So many people may not know that they have syphilis. They may not get that rash or those sores. But it is something that is tested as part of routine healthcare if you have a relationship with a health provider who is aware enough that they should be testing people, regardless of what their history is, on a regular basis to be sure that they don't have it. And I just also want to, you asked about,
What makes it so explosive? Because people don't realize?
So part of it is that, yes, so part of it is that people don't realize they're not getting tested. It also is that, the treatment regimen for syphilis depends on what stage we catch the disease. So you could use, it's a very simple treatment. You could just get one dose, one shot of penicillin, or you might need one dose of penicillin for 3 weeks. You can also use a course of oral antibiotics to treat it too. But it means that you have to come back to care. And so for people who might just be coming for one thing, who may not have good connection with their healthcare providers, they might miss it. They might be missed. They might not get tested. They may not follow up. And it also means you have to test and treat your partner as well. And that entails a conversation that might be difficult. Do you have syphilis? Did you infect me? People may not always be willing to have those conversations with their own sexual partner. There's a lot of stigma, a lot of risk, especially if there's not an equal playing field in the relationship either. So there's a lot of factors, but the main factor, which is something that I really feel when I take care of patients, is that we have both systemic and individual racism that impact these things, right? So people, especially in Black and brown communities, don't always have good access for a variety of historical issues, which we'll probably be getting into. They may not have a trusted healthcare provider. Even when they see those healthcare providers, those individual bias and racism comes into play, where people don't take the time to explain, this is what I'm doing, or even do the appropriate testing for that person. So there's a lot of gaps, and they've all come together to cause this explosion. I would also say, just in terms of timing, we see a lot of health conditions worsening after COVID because people have not been getting or have had access to routine primary health care. So it's just important that people have a connection to a provider like Justin.
And I find a lot of people come to see me and they think they've been getting tested for things like syphilis, and they actually haven't been, right? Because in your 15-minute primary care visit where they're trying to tackle 12 different things, you say, can I also get tested for STDs? And they go, yeah, pee in this cup. And they forget to click the button for syphilis, or they forget to click the button for HIV. And so I don't think all of it's purposeful, right? I think people are busy. And so I would encourage people to be their own self-advocate. Hey, did you check me for syphilis? And know that an RPR is a test for syphilis.
So just because you pee in a cup, they're not testing for it?
Exactly. Syphilis has to get tested by blood.
I would have thought I thought I was safe if I pee in a cup.
Yeah,
that's great to know.
Yeah, and that's the stuff that I think when we talk to communities, they're like, no, I get tested all the time. And I'm like, did you get your blood drawn? And they're like, no. And I'm like, okay, we're going to get your blood drawn today. And those are the little things that I think can make a big difference for folks when they go to see their healthcare provider. By the time you finally get through the door, you call, there's an appointment in 4 months, right? You want to kind of know what to ask for when you get through the door.
Right.
So 2 questions. When it comes to syphilis, because we're on that conversation, one, can you get it orally? 2, what is kind of the general, what are we seeing people not knowing them having it? What's the general time they're coming in? Are you seeing people that had it for a year and didn't know it? Are you seeing people that had it for 6 months and didn't know it? What's that average time frame that people are just something's wrong with my body, I probably should get tested now?
I will say, I think it's really variable in what happens. I will say the number one thing that I think people feel bad about is they come in and I'm like, so you have latent syphilis or you have secondary syphilis. And they're like, wait, I thought you got a sore on your penis or something. Why didn't I get a sore? I'm like, well, maybe it was in your mouth. And it was, and it's a painless sore that goes away in 2 to 3 days. So who would pay attention to that, right?
So you can get mouth syphilis.
So you can get a sore in your mouth, right? But I think knowing you can get syphilis from oral sex is important, right? And letting people know that just because you only do oral sex doesn't mean you can't get anything else, right? And so making sure you're getting a throat swab, making sure for chlamydia and gonorrhea, make sure you're getting the syphilis test. Am I worried about HIV from oral sex? Not super, a lot, right? There's some risk there, but I'm much more worried about chlamydia and gonorrhea and syphilis that way.
So for the chlamydia and gonorrhea test, you need to get a mouth swab?
So you need to swab whatever you use. That's what I tell people. So if you use your vagina for sex, you got to swab your vagina. If you use your rectum for sex, you got to swab your rectum. If you use your throat for sex, you got to swab your throat.
This is all very helpful for the audience. For me too. For me too.
For the audience. Yeah.
I mean, if people are like, I didn't know that you had to get a blood test, for syphilis, because, like you said, a lot of the reasons why people do stop going to the doctor is because it takes so much time to get an appointment, and then when you do, you're only in there literally for. I've had appointments literally probably 8 minutes max, and you kind of leave worse. You feel worse when you leave, than you do coming in. And it could be a little, discouraging and disappointing. So, finding online tools and resources from people that actually do the thing is so helpful. Yeah.
I'm sorry. Thank you.
Have your diva moment. I love a microphone.
So unnatural. This is a systemic disease. Systemic, so it's the whole body. It's, as Justin said, it's not just the mouth or the penis or the anus, the vagina. And yes, we see people of all different stages, but it's always interesting when we have an 80-year-old woman who's been widowed for 20 years, and she's starting to get confused, and part of the workup in primary care includes syphilis, because you can, again, get dementia from it, and the syphilis test is positive. And people are asking, like, what happened? When did this happen? And it's happened 20 years ago. But
20 years with syphilis, that's great.
Yeah, and we've had some people who come to our clinic. They may have gotten tested, again, when they develop symptoms of dementia or other things, but never got it as part of routine testing. And I think, yes, the appointments are busy, but we also have to take time to realize you could be in a monogamous relationship and still have an STD. It's part of our routine healthcare.
Yeah. Don't trust that person. You know what I mean? Just go get checked.
Well, and I think I just want to jump in. I think the other thing that happens is there's like this blame game that kind of happens. And so I try really hard to make sure that that's not the thing. And I'm like, who knows? Maybe it was you, maybe it was him. Who really knows? Who cares? Let's just treat it. Right? And I think people place a lot of onus on it. Now, if you get syphilis 3 or 4 times from the same partner, okay, that's a different story. Right? Like, we got to have a different conversation about that partner. But I think I usually say, like, you get one freebie of, like, mistakes happen, who knows when this happened, and then have a deeper conversation.
Completely agreed. But many people, even with HIV, they have a diagnosis, they insist on bringing their partner in to get the diagnosis too. The partner has no idea, and they're devastated. People, this is just emblematic of the fact that we don't have access to information and testing. So again, right, you can still trust the person, but they may not have gotten tested. So this is just to be normalized as part of the things that we do, as part of self-care.
That is amazing. So how long does it take to get treated? Does it depend on syphilis, most specifically? Does it depend on how extensive the syphilis is? I don't know. That's probably not the right term.
No, that's a great question. So yeah, it depends on the stage, whether we think that it was acquired in the past year or whether it's been longer than that. So if we think it's been acquired in the past year, you can get just one shot. So how we know it may have been acquired in the past year is if you develop symptoms right around the time you come in for testing, and then we're like, okay, we caught it. Let's go ahead and test you. Or you get tested every year, and then we can see, this is a new infection. Let's just give you one shot of penicillin. But if we don't know, we have no history, then it's at least, it's at least 3 weeks of treatment, whether it's with the penicillin or an oral antibiotic. And if it goes even longer and we are concerned that it might be affecting your organs like your brain or your eyes, then it requires intravenous penicillin, intravenous antibiotics. Most people are not going to have that. But the goal of testing is to make sure that we can get quick, easy treatment, or just figure out what's going on. Either way, I should say, I don't mean to make this sound harsh. The antibiotic we have, penicillin, again, is just very generic, right? So it is easy, and you can cure and you can treat this. Rarely, and sometimes we see this more with pregnancy, we might have a trouble with clearing it, or there may be the case where someone is getting it again and again and again from the same person, and that gets to be a little tricky. But in general, it's easy to treat.
2 questions. One is, what are some other STDs that are on the rise, or having an uptick in this community specifically, like in Boston or BIPOC communities or around this area in general? And then also 2, after 20 years though, what does that do? Does it make you infertile, or the
long-term effects?
Yeah, what's the long-term effect? Because wasn't the Tuskegee thing with syphilis?
Yes.
Yes, it absolutely was with syphilis.
So I will take the first part. I'll give you the second part. Do you want to answer the syphilis part first? Okay.
Okay, yeah.
Do
You want me? Yeah, you want? Yeah, I can
Your
do that.
call.
So yes, syphilis can lead to other, like, so I mentioned it's a systemic disease. It can lead to issues with your eyesight, with dementia, with cardiac problems. Syphilis and other STDs can be implicated in infertility as well. So yes.
As far as chlamydia and gonorrhea go, they are also on the rise all throughout the country. We see it here in Boston. I treat tons of STDs in my clinic all of the time. And I think really knowing, I try with our nurses to be really thoughtful about, like, if you're worried about getting anything, just come in. Just do the test, right? I would rather you come in and do the test and be nervous about the test and get an answer that's negative than not do the test and just live with chlamydia or live with gonorrhea, because they can be asymptomatic. And they're more frequently asymptomatic in places that aren't the genitals. So like in your throat, people would never know that they had gonorrhea of the throat unless they get that swabbed, right? And so we really are seeing a lot of this increased, particularly in what we call extragenital, outside of your penis or your vagina, sites of STDs, right? Because people are like, well, I don't want to get
this is
pregnant.
safer. Like, I'll just,
Right,
like,
it's safe. Right, exactly. Hawk to it. But you really you have to like
Off the
think. But really understanding, right, like that poses this risk, right, for chlamydia and gonorrhea with that right there, right? And so those are the things that we think about. And getting more people to do more of the testing is how we actually, like, if we all just agree to go and get tested, we can get a handle on this. But people have to sort of agree to get tested and tell their partners if they test positive. And so this is what I see all the time. I tested positive and then I ghosted my roster, and I'm just going to get a new roster, right? Because I just don't want to have to talk
People
to them
say
about
that?
it. What?
People say that?
People do that.
They do that?
Because they're nervous to have to tell someone, right? Yeah. And like, there's different ways to do it. You can have this like very thoughtful conversation. I've had patients who are like, I just accuse everyone I slept with of giving it to me, and then I don't have to worry about feeling bad. And I'm like, that's one way to do it, right?
The toxic pathway.
The toxic
Yeah.
pathway. But I think really understanding, like, if we can have a less stigmatized conversation about STDs, we actually will see rates go down.
And which one's the most dangerous, do you think, out of like all three of the ones that we just talked about? Chlamydia,
HIV.
syphilis, and gonorrhea. Which one's the most dangerous at the moment?
I mean, they all cause their own things. You know, I mentioned that, you know, chlamydia can cause infertility, gonorrhea can as well, as can syphilis. With syphilis, we see these longer-term systemic effects. You know, I would say that long-term syphilis can be a huge deal. Gonorrhea, however, can cause, and many of the STDs can cause issues with pregnancy as well, and you know, transmission to babies. And unfortunately, gonorrhea has become more and more drug resistant over time. So we've, you know, across the United States, departments of public health are really nervous about this because we're losing the effectiveness of our frontline antibiotics. And so that comes about when you start treatment, you may not finish it. It also comes about from, you know, the fact that you know, we are one world, and so some places have more resistant gonorrhea, and then it travels here. So even though medically it might not be as dangerous, it is becoming more and more difficult to treat. So it's something that we want to diagnose as quickly as possible so that we can get people on the right treatment. Otherwise, they're at risk for continuing to transmit, and then they may continue to have these never-ending symptoms.
This might be a divisive question, but someone did ask us to ask this. Like, who is the bigger culprit of the sexes that like are transmitting the disease? The disease is like, is
Male or female?
Yeah.
No.
I mean, I'm sorry, like I always blame men, but you know, what Justin and I were talking about, we really do have a non-judgmental approach because people don't know what they have, you know, and no one, I never fault anyone, right, for transmitting because they don't know. They may not even know the implications, especially if they're asymptomatic. As we talked about, one of the biggest myths is if I don't have symptoms, I don't have an STD, or if I'm asymptomatic, I can't transmit. So there's a lack of knowledge there too that implicates that. Biologically speaking, however, it is easier for thinking about a heterosexual relationship. Of course, there are lots more than that, but in a heterosexual relationship, it's easier in most cases for men to transmit to women. And that includes for HIV. Doesn't mean that one person is more at fault, though. Just want to go to the language of the question.
And I also think that when we talk about populations of folks, like I always think of like the prevalence of how much is happening, like how many cases of chlamydia dictate how many more cases of chlamydia there will be. Like if there's a lot of prevalence in a community, there's going to be more incidents in a community typically, right? And so when you think about like I take care of a lot of men who have sex with men, right? And so there's more STDs, so there will be more STDs, right? Like just because there's more of it around, so it can be transmitted more frequently. And so I think knowing like what population am I in? Am I at risk to get a lot of these things? I should get tested more frequently, right? And we all have guidelines about how frequently people should get tested, but I have people who are like, I need to be tested every 2 months. I'm like, great, let's do it, right? If you know you're active and you know you want to take care of yourself that way, that's great. I'm down.
Very responsible.
I think it's fantastic. And one last thing about this axis too, men are more likely to be asymptomatic with
what?
chlamydia. Men are more likely to be asymptomatic. They have less symptoms with chlamydia, and maybe so with gonorrhea as well. So just another point to the importance of testing. You don't, just because you don't feel it doesn't mean it's not there. And we see the same thing in our communities with hypertension, diabetes. So many of my patients say, I didn't need to take my medications because I felt fine. And so this is part of the importance of having a good established relationship with a provider where you know, depending on your risk, this is just something that you do.
For men though, if they are asymptomatic, is there like, other than like if you transmit it, it's going to do a lot of damage to your partner. Like if you're asymptomatic, is there any long-term damage that the men are going to face, or is it just from them just like getting in contact with other people? Like that's the issue.
So I will say, I think asymptomatic STDs or STIs are more insidious, meaning they're like worse actually than people who are symptomatic. Like if you have a discharge, you're coming in, right?
Yeah.
If you got a drip, you're coming in. You're not living with that. That's uncomfortable, right? The people who have this asymptomatic like oral gonorrhea, and then they like hurt their knee and they get a sepsis in their knee that's now gonorrhea in the knee, right? Like, right?
crazy.
What?
Yeah.
You're
That
welcome,
can happen?
guys. Yes, that can happen. Yeah. And so like those are the things that I think like to me that's super dangerous, right? But you would have never known. How would you have known, right? And so it's not a problem till it's like a big problem, right? And that's why like if we can treat these things, if we can catch these things early, treat these things early, they never become a big problem, right? And so I always say like don't rely on your partner's test to know you're good, right? We see that all the time. Oh, she got tested, I'm good. No.
Our body is not your body.
Right, exactly.
Yeah.
And so I think really just encouraging people, even if you think there's no way you have anything, get tested, because if you have an asymptomatic thing, it's very easy to treat. It's way harder to treat gonorrhea that's in your knee or syphilis that's now affecting your eyeballs, right? Like that's not fun.
So, okay.
Sovereign now.
So we talked about Dr. Cassandra, you mentioned earlier, okay, you getting syphilis and it possibly, or it can give you dementia and also in your eyes too, but also talked about like when you go get these tests, you have to, it's a certain specific test that could get you a certain type of result and you're getting mistested. So let's go down the line. If you think you have gonorrhea, what test should you get?
Great question. So if you're getting gonorrhea, so I think Justin alluded to this a little bit, you should test what you use.
Okay.
So you can get a urine test, you can get a throat, you can get a rectal test. We won't get a blood test unless there's a concern that there's something in your system that shouldn't be there. But those are the more important things to do for chlamydia and gonorrhea.
Okay.
For a syphilis test, you're going to get the blood test. For an HIV test, because I include that in the STDs, you should be getting a blood test as well.
Okay.
At least one lifetime, but more when you have new sexual partners.
Okay, I met a man once. I was on my way from work. And I'm always
story, let's
fishing
go.
for a story, right? And he was taking a picture, and I was like, "Did you get a picture of me?" And we started to talk. And he said that he was here. We were over by Mass General, and he said that he was here because he was getting research done because he was diagnosed with HIV in his early 20s. He was probably like 60, but he literally looked no more than 40. He looked so good. He was from Texas. And he said that through the story, he said that even though he was diagnosed with HIV, it doesn't show up in his blood. And he's never had any symptoms. He's felt great. And so how does that happen?
Yeah, so that is an incredibly rare exception that I want people to know about. That is that is that's less than 1% of the population.
Wow.
He has something, and that's why he's being studied. He is what's known as an elite controller or a long-term non-progressor with HIV. Those are people who, because of an issue probably related to a mutation, a change on one of their immune cells, their cells actually have this reduced ability to take in the HIV, and so have a less ability to be infected by HIV. And what that means is the body can suppress the virus. So what he means by the virus is not in his blood. He's infected. But when we check his blood to see how many copies of the virus, the HIV virus, are in the blood, and that's how we check to see, how active HIV is in a person, it's coming up as 0. Because his body is controlling it. It is incredibly rare. It's 1% of the population. We do have a few people in our clinic. What we've seen over time is that usually 10, 15, 20 years down the line, the body will start to lose the fight and people will need medications. And we also see, in addition to that, even if the body is controlling the virus, there's a lot of inflammation in the body from all that work. And so even people who are long-term non-progressors, even though they're not going to go on, while their body is fighting it, to develop opportunistic infections, they're not going to lose a lot of weight, they're not going to develop all those cancers that we think about with HIV, they are more likely to have heart disease than the general population. Something that we're still trying to figure out. But we're also trying to figure out what makes these people tick. We seem to know in most people that it is a mutation in their immune system, but it is incredibly rare, and this is not the rule for most people.
Thank you for that.
What's the I was looking online and it said like something about stem cells curing HIV. What's that about, or did you hear anything about that?
Yeah, absolutely. The first time this happened, it was probably about 6, 8, maybe 10 years ago.
It was Magic Johnson, was it? I don't think
No,
It was not.
it was not. It was someone that we used to call the Germany patient. I think his name was Timothy Brown. And the first time it came out, my patients all came in. They're like, "There's a cure. There's a cure." So it is true that there have been at least 4 people who have been cured of HIV, and yet at the same time there is no cure. And I'll explain what that means. Those people who have been cured, including that very first patient, had a really aggressive type of cancer. He had leukemia. And what that meant is that he had to go under this life-threatening procedure where they got rid of his entire immune system. They irradiated his immune system, and they gave him back stem cells from another individual. That individual, I think that was a really great segue. That individual that they got the stem cells from had that same mutation I talked about on their cells that made their cells more resistant to HIV infection. So if you imagine, what you've done is you've just irradiated the entire body. All of the immune cells that were harboring that HIV have been killed off. Any lingering HIV virus that's hanging around is going to have difficult time finding an immune cell that's going to let it in because of the mutation that man got. And so they kept him off of treatment because he was recovering from this really, really dangerous life-threatening procedure. He was off of medications because he just couldn't take any more toxicity. And they noticed after a few months and then after a few years, his virus was not coming back. They could not detect the virus in his system. And so for that reason, they've done for people who are who are infected with HIV, who are living with HIV, and need this kind of procedure, stem cell replacement. For some people, they've been part of a study that have done similar things. It hasn't taken for all of them, but so far 4 people, including him, have achieved a cure. You never know. Sometimes they check every few months to be sure that it sticks. But it's something that most people can't get because, again, it is life-threatening to do this. When you have this, you're at risk for a whole lot of other infections because your immune system takes time to root and to come into fruition. So it's not something we do for the average person. It's dangerous, expensive, life-threatening, but it is something that we hope to learn from in terms of coming up with a cure. And I always tell my patients, I really do believe it. I think sometime in our lifetime we will achieve that cure, but that is not it for the general population.
Yeah, so wrap it up.
Has there been a lot of HIV that you guys have seen in the migrant population coming over?
Yeah, I do a fair bit of this work, and I work not just at the hospital. I also work on a van that does free HIV and STI testing in the community. So I often run into people who like don't even know how to get insurance, don't know where to find a provider, and I think there's two sort of types of groups that I think of in our migrant population. Some come knowing that they have HIV, and I had a guy the other day come in from Brazil. He's like, I need a new provider. I need my medicine. This is what I'm on. Can you prescribe me this? Super easy. Those are easy visits, actually. I'm like, great. You know everything. Right. And then there's this other population of folks who come who have not had access to regular healthcare before. And in their routine visit with us, we're just doing sort of all of our normal testing. We put that HIV test in there, and it comes back positive. And so now you're like newly here in the States. You don't have a lot of resources or support. You have this new diagnosis that you may or may not understand, based on the level of education that you have from your home country. And so we have to do a lot of work around like, what is HIV? Why is it so important that you have it? And what can we do about it? So that's what I see a lot. And I do think that that's something that we could do better of getting more folks through the door and getting more folks tested and sort of onto treatment quickly.
How does that conversation go? Like when you say like, what is HIV? What it is like? How is that usually received? How does it like, how does that conversation go when goes down?
I have the unfortunate privilege of having diagnosed many, many, many people with HIV, and I have never had the same conversation twice, ever. And it's always different, and people's reactions are always different, and what people say is always different. And we used to do the finger sticks, and you'd know in 10 minutes. Then we did the blood draws, and so I always say like, take a minute, talk to people, and figure out what they want. One that struck me, it was like the third person I think I'd ever diagnosed looked at me and said, who's going to take care of my cat? And I was like, well, you. Like, what do you mean? You're going to take care of the cat. You're not going anywhere. Like, you'll be fine. But knowing that in that moment, what that person wanted to know was about the cat. And I think some people are going to be like, I don't know anything about HIV. Can you teach me about it? Some people are going to be like, I can't talk about this right now. Can I talk about anything else right now? And so really sort of that's how I do it. I take the lead from whoever's in front of me and what they need to know.
I would also say this, just thinking about the migrant population, this is a bit of a tricky topic too, because when we talk about this, what we're really talking about is a breakdown of healthcare access. It's the same issue that we see in Black and brown populations, right? So I wouldn't want people to get the idea that, oh, look at these people. The same thing my cousins heard, because I'm Haitian, when they, right, like,
Patients in the building.
I know, we're taking over. So, like, when my cousins would come, my grandmother brought my entire family over. My cousins would come. They would go to middle school, fresh from the plane. They would be mocked. They would say, you're bringing HIV into this country, right? That's part of the reason why I do the work that I do, is because of the stigma. If I could do it all over again, I would actually just go back and work on stigma. Because, just like we talked about, that's the reason. If we could get rid of the stigma, we could really lessen the sting of the disease and just normalize this. HIV on treatment is another chronic disease. And the reason why we're talking about it in this population is because they have undergone things that I would not have survived. Walking across a jungle, fending off predators, human and animal, and undergoing and then being exposed to sexual assault and rape. So many things, so many reasons why this is happening. But I think, again, the most important thing that we say is that we want to change the understanding. Many people who are coming, just like people we talk to here, may still have this view of HIV as their death sentence.
Right.
And when I take care of, I still diagnose a fair amount of HIV in my pregnant patients. And so, thinking back about the reactions we get, yes, they're all very different. The HIV in most of my patients becomes the last problem on their list because it's so well managed. We have such better medications for it. A lot of the issue that people face is the fear of what they've been hearing in the past. If you come from Haiti, what you see in Haiti is very different what's happening here. It's not right, but we have access to so many things.
What are the biggest misconceptions that you're hearing, like when you first diagnose people? Do they think they're gonna die like within like a month, or do they think like everyone's gonna shun them? Like what are you hearing from people in the community that are coming and you're diagnosing them? What's their biggest fears?
I think the fears depend on who is being diagnosed. And I do think they kind of have trends, right? For like men who have sex with men, sometimes it's like, oh my God, people are going to find out I'm gay. Or, oh my God, people are going to find out I have sleep with men. It becomes this they can't come to the clinic, they can't talk about it because this bad thing has happened. Some people, as you sort of alluded to, like feel like no one is going to, my family won't talk to me anymore, this won't happen. I also think that there's this other population that really and truly, they struggle to take it in and to believe it. And so there's this level of denialism of like, I just can't bring myself to talk about this. Tell me what you want me to do, because I don't want to talk about it. I will do whatever you tell me to do, nurse, doctor, whatever, but like, I don't want to talk about it. I'm just going to go through the motions for right now. And quite frankly, I think that's okay sometimes. Like, I think sometimes, great, let's just go through the motions until you're ready.
I would say I completely agree. I've had patients who I've been taking care of for 12 years now, and I didn't realize this when I was a younger attending, but I do now. They will never get over the shock, whether they felt the betrayal or whether it was a sexual assault, but there's this mark they feel internally. And one of the best things for some of my patients that ever came about was the injectable antiretroviral regimen that replaces oral. I'm not trying to be an ad here, but I've had some patients who for the first time really engaged with me. I was like, oh, this is who you are. And I'm not saying this is the same for everyone, but for some people, not having that pill bottle at home that is a threat to disclose their status to their partner or just a daily reminder of the disease kind of allows them to feel normal again. But another thing that I hear about too is that people have this ongoing concern about or feeling of themselves as like potentially contaminating others in their midst, that they may infect their children just by hugging them. Or, I've had patients who like bring their children in and insist that I test them because the child touched a razor that they used. And we try to talk about again and again, this is not how it works. It's not how it works. Your viral load is undetectable. You're okay. You're not going to pose a risk to other people, which is another thing we talk about too. Undetectable equals untransmittable has also been a really powerful thing to understand that we've learned and that our patients now know. But still, there's still, even if people know, there's still the thought that they're a risk to the people in their lives. And that's something that people spend months to years or their whole lives working on.
Yeah, because I seen around, it was a few years ago, people used to like be afraid to drink out of somebody's cup, or like they drink out of somebody's cup and they were freaked out that they might catch like HIV, and it doesn't work like that. Like you would have to have like, was it gallons of saliva to maybe, or even, I don't even know if that's a...
Yeah, I can, so theoretically, yes. And the theoretically I talk about, it's not the cup. It's not drinking or using someone's utensil at all. What we're talking about with the saliva is something called pre-mastication. We talk about and even this is a theoretical risk. There's theoretically people in the literature who have transmitted. Dustin's shaking his head no. There's some people who believe that they may have been transmitted or their children may have gotten transmission this way. It's a little unclear. But what that involves is like chewing someone's food while your viral load is detectable and then depositing it into their mouth like a baby bird, like some cultures do for their children. I am also skeptical about this happening, but it is in the literature, and some people theoretically have had transmissions this way. So it's definitely, I would say, not a concern. There's certainly other things I worry about, like even backwash with my own kids. Like I don't drink from other people's cups. But HIV is not at the top of my mind as a reason why not to. And I think that's wonderful to talk about too. Like maybe just break this down right now. HIV is transmitted through sexual activity, through sexual contact. Usually we think about anal or vaginal contact, blood transfusions, and from perinatal transmission from a parent to a child in pregnancy or delivery. Those are the main modes. So not a hug, not a kiss, not even a French kiss, not, drinking from someone's cup. People worry about the sharing of the toothbrushes. I would say that's a very low risk as well.
I think all of that sort of also suggests, though, that HIV is profoundly lonely. And I think when we talk about like these new diagnoses, that's what we see a lot, is that there's this profound loneliness of, I don't even want to share a fork with somebody, I'm worried. And oftentimes it's from the person living with HIV themselves who's heard these myths, and they're like, but what if there's a chance that if I brush my teeth and then my spouse uses my toothbrush, they get it? And I'm like, okay, honey, you're going to be okay. And the spouse is like, I don't care. And they're like using the toothbrush. And they're like, your doctor told me undetectable equals untransmittable. I'm fine.
Yeah.
But we still see this really isolating loneliness that happens for the person living with HIV.
Are there a lot of, from what you see, well, I wanted to ask one more question and go to a break, but I got two. Are there a lot of married couples that you see still one is infected and the other is not, that are still able to, coincide and live happily?
Absolutely. This is actually the fun part of my job. This is why I love doing HIV and pregnancy in particular, because we may have a couple that's fractured at the very beginning. There's, the thought of like, well, I have it and you don't have it. It's always bad sometimes when it's like he has it and she has it and then she's pregnant. But many times it honestly is the pregnant person has it, the other person doesn't. How can we come to grips with this? Why doesn't he have it? Like, we've been together for 10 years.
Right.
Now he's like, why doesn't he have it in the first place? So we work through all of that, and we see, a year or two in, especially in the past 10 years where there's more understanding about what this actually means, and that, we bring down the rhetoric, we bring down the stigma. We absolutely see people who are coinciding, living happily, having more children together safely. And I love also seeing people who may be single when I first see them, whether it's in my general clinic or the pregnancy clinic, and are struggling through the stigma of like, oh, I want to date, but I don't want to tell anyone about my disease, and then are able to find love. And I kind of use that as examples for other people who are like, I'm just never going to date anymore.
Very interesting. Thank you.
And I think the concept of undetectable equals untransmittable, just to break that down, that means that someone living with HIV, when we test their blood, we have an undetectable viral load, meaning we can't see particles of the virus in the blood, and that person cannot transmit HIV to their partner, even if they don't use a condom. Right? And so for couples who were together for years and still using condoms, and we've been together for 20 years and I still use condoms, to get that news, you don't need to. It would be okay if you had sex without a condom. All of a sudden, they're like, oh my God, my relationship changed. Like, I feel so much closer to my partner. I feel like it's such a good thing. And, when we talk about sex, we got to talk about, it feels good.
Yeah.
Right? Some things feel better than other things. Right? And if I can help you with your partner feel better, why wouldn't I want to do that? So
That's right.
I think serodiscordant couples, I have a friend who calls them magnetic couples because there's a positive and a negative. I think can live these very healthy, happy sexual lives.
Well, what you said actually is going to lead into my last question before we take a break, is how can people listening to this, how can they protect themselves against HIV, gonorrhea, syphilis, and chlamydia?
So there's lots of things you can do. I will quickly just list off, we have things like PrEP and NPEP and DoxyPEP. And so those are all medications that can help prevent HIV, either before you're exposed or after you've maybe been exposed. And we have things like DoxyPEP now for some populations where we can prevent things like chlamydia and gonorrhea and syphilis after you've had sex without a condom. Right? And so those are all really cool innovations that we have to help people. And then the tried and true, use a condom,
right?
Get tested with your partner before you have sex with them. All the good stuff still applies, but we have some new tricks in our bag too.
I would also add to that, that is the answer. I guess I would also say, know your risk. Because so many of us, in the population I take care of, my panel is mostly women of color, Black and Latino women of color, women, and or people. And in the BIPOC community, our risk is higher. Without any additional risk, we don't have more sexual partners. We don't have increased risky sexual behavior. By being a person of color alone, our risk of HIV and STDs is almost twofold higher, depending on the population. It's higher for others. And so what that means is we are at risk and we should get tested. Even if we think, we've been in this one monogamous relationship, it's just part of self-care. We may be, depending on, what our lives look like, we may be a candidate for PrEP. And I think there's this misunderstanding of what PrEP and PEP, who they're for. They're really for everyone. But the misconception I see among many people of color, especially Black women, is that, oh, that's for gay men. No. So understanding in addition to all of those things in the arsenal, understanding that they are for all of us, and we need to understand what our risk actually is.
That's something I definitely want to dive into the next part.
All right, guys. Thank you all so much. We're going to take a quick break. What's up, family? Welcome back to our episode of Sexual Health and STDs. I would like to introduce our friend to the right, my far right, John Mandy. John Mandy, say what's up and introduce yourself.
What's up, family? How are you all doing? I hope you're doing well. Again, my name is John Mandy. I work at the Boston Children's Hospital. I'm a behavioral health counselor. And so I hope I might be able to contribute to this conversation.
Let's go.
So one thing that I wanted to just like explore a little bit more was you said that like when people were getting tested and we're talking about stigmas, a lot of like women of color would say like that's for gay men. Could you elaborate on more of that like conversation?
Absolutely. So, for a variety of reasons, women of color, we have been socialized on a variety of viewpoints about what we can and can't do as women, and then, what we're at risk for. And so we are told, right, to, whether we do or not, we have a limited amount of sexual contacts, or maybe in monogamous relationships, and therefore we're not at risk for any sexually transmitted disease. In addition to that, there's been a really pervasive, toxic, harmful narrative for everyone involved that has also been homophobic from the very early days of HIV, clearly. In the very first name of HIV, right? It was given the name gay man's disease. And we knew even from the beginning that was not necessarily the case. So it's easy. It's human beings, I think, when we're faced with something that's scary, that's frightening, we want to other it. We want to distance ourselves from it. And so if it's something that we feel is not part of our narrative, then that's someone else's problem. Marketing also contributes to this as well. What do you see when we look at the ads for a lot of HIV medications and PrEP medications is white gay men. Or white men who have sex with men. So there's been a lot more diversification of those ads over the years, but the pervasive narrative of the fact that this is not a disease for women, especially in communities that, including migrant communities, where sex outside of a dedicated marriage relationship is frowned on, is just seen as this is not part of my life. And so when we have, it's not just syphilis, but when we have the 80-year-old woman who comes to us with a new diagnosis of HIV, everyone is very confused, sometimes including their healthcare providers, who may not have tested them. It's part of the reason why in our hospital, including in the family medicine clinic, we've made changes to have this lifetime HIV test, right? So if someone comes in and they're above the age of 13, which is when the CDC says people should be tested, so between the ages of 13 and 64, and they have not had at least one HIV test, it triggers and asks the provider whether they would like to order that, just as a reminder. Because the bias continues for providers as well. It's not just the women themselves, it's also the provider saying, oh, you're in a relationship, you don't have sex outside of this relationship, your lifetime number of sexual partners is low, you're fine, you don't need this. Understanding this is, again, just part of our regular health. This is part of our health, and that should be a screening that's done. There are a lot of other reasons besides, but I think the cultural narrative, both internally in communities of color, and then for what's projected, in terms of who's getting these medications, who's being portrayed as getting them, and who's being assessed and screened for them, are being told this is not for you.
I have two questions that were like kind of derived that the audience gave us. In you're Haitian, I'm Haitian, so we know like how religion plays a big thing. So one of them was like, are most people in the medical field like atheist? You know what I mean? How does that play into it? And also too, when people think about like holistic health and have that alternative, think of people like Dr. Sebi, and like what's what are your thoughts on him? And thoughts about that practice?
Yeah, maybe we could both both talk about faith and HIV, and I'm happy to talk about Dr. Sebi and other traditional health as it relates to HIV. So no, I would say that what you see for clinicians probably reflects the general population. There are a lot of people with deeply held faith. In fact, when it comes to HIV work, I know in our clinic, a lot of the people who first started caring for people living with HIV were people who were very deeply religious. One of the people who was kind of the vanguard in our clinic was a Jesuit priest. Not many people knew that, but he was a Jesuit priest who he's since retired, but he was one of the first people and felt like it was a mission and a calling to care for people living with the virus. And I would say that a lot of patients who come to me, again, coming from, I see a lot of Haitian people, a lot of people from the Caribbean, and they will pray and pray and pray when they first get the diagnosis, and sometimes their prayers are for God to take this away. I've learned since the early days of treating people that I have to be very careful about the words that I say. I will say, our goal is to get you to undetectable. Our goal is to treat you and get you undetectable. But once you are undetectable, it doesn't mean that you're cured, and it means that the virus isn't hiding, it's sleeping, because the medications is doing that. It's killing off the virus. It's causing it to fall asleep. If you stop the medication, it'll wake back up. Because people were hearing undetectable and saying, God answered my prayers, going off their medications. And the next time I would test them, I would be like, oh, what happened? Your virus is back again. And then they would feel betrayed. So I have a lot of conversations with people about the fact that, God also created the people who created this medication. God also had a hand in creating this medication and weaving this into faith traditions. That doesn't mean that you're abandoned, doesn't mean that you're cursed. It's another disease like diabetes or high blood pressure is what I usually relate it to. And we're lucky that we have this medication to treat it. But it's not an either or by any means. So there are people who are agnostic, there are people who are atheists, there are people who are practicing many different religions within the health field, just like anywhere else.
And I think the interplay of religion and HIV is even more interesting, right? Because that intersection of if you are gay and you have HIV, right? Is this your punishment because you did those things? And so I think for people who are profoundly religious who get HIV, they have this different relationship with God now. And I actually think as a healthcare provider, I talk about religion with my patients. I talk about whether they go to church. I talk about those things because it's important to them. And I think there's people who can find religion to be really troubling. But I also think religion has saved a lot of people and God has saved a lot of people. And to ignore that fact would be negligent on my part. Right? To say, what is the role that God plays in your life and how does that play out for you, regardless of what I think. Right? Because my job is to help you sort of live your best life. And that's kind of how I come at it. I was born and raised Catholic, right? And so I was taught, you're supposed to, help other people. That's how I got into this whole thing, right? And that's why I do addiction and HIV work, because the one thing that, as a Catholic, I think I still have is, hope. Do you know what I mean? That's the one thing I was instilled with. It's just, there was always hope that it will be better. That there will be something better, and that's what I try to bring with me. I will let you talk about.
No, I think this is a great question in terms of interplay, in terms of what exists beyond traditional medicine to treat HIV, right? This is important, and so yes, faith is a really important part of that. So I find that a lot of my patients are interested in understanding how their traditional healings might fit into care. How do they replace, improve, or coexist with traditional HIV medications, which is where I'm trying to go. So Dr. Sebi had a really important message to say, and I think the fact that we're still talking about Dr. Sebi today shows how important it is for people like us, BIPOC communities, who have been disenfranchised, who have been taken away from our traditional faith and healing elements, right? We weren't allowed to access our traditional healing elements in many cases through colonization or slavery. Many of us are trying to get back to that and understand how the land can provide, how we can heal ourselves. That is really, really important. So Dr. Sebi advocated for diet, and I have had patients who have followed his teachings, who follow this alkaline diet, and they feel good. I will have to say though, of all the people that I've treated who have been on his diet, they continue to have HIV. It wasn't a cure, and we've never seen diet to be a cure. Diet can really improve people's hormone balance. It can improve their energy levels. It can improve a lot of different things. But diet has never been proved to cure an infection. And, you know, I've had people who have even developed AIDS-defining conditions, right? So when their HIV becomes so bad that their immune systems become weak enough to the point where they're at risk for opportunistic infections and different types of cancers. I have certainly had that happen before. And then, you know, I've been able to maintain trust and relationship with that person while they've gone through that journey of trying to treat themselves with the diet, with Dr. Sebi's traditional teachings or other teachings. And we've made a decision together, okay, we've had just the diet, let's try the diet and the medication together. So I don't view them as incompatible. But what I will say is that these medications do exist. In the early days of the epidemic of HIV and AIDS, there was a lot to find fault with in the medications. They were toxic, they caused a lot of side effects. What we have now is a sea change different than that. People take these medications now and it's like popping a multivitamin. It's important because I have to take them every day, but it doesn't interact, it doesn't cause the amount of sickness that we saw before. And right now, it is one of the important and probably the best tools in our arsenal to treat HIV until a cure comes on the horizon. We have not, beyond the stem cells that we talked about in those 4 people, seen a cure. And that includes from Dr. Sebi. I know that one of the audience members mentioned, you know, there are testimonials about this. The problem with the testimonials is that it's a snapshot in time, and we don't necessarily follow people over time to see what happened to them, to see what the trajectory was, you know, 10 years ago, since 10 years, since 15 years. Again, in my experience, the patients that I've treated have needed the medication, and that's okay. That's okay. I will say that we in medicine have struggled, and many of us are a lot better, in incorporating cultural and traditional practices along with medicine. It can absolutely be done. I remember I did a rotation when I was a medical student in Arizona with a clinic that had a pharmacy, and then right next to the pharmacy, they had the complementary medicine pharmacy. So you could get your herbs while you got your medication, and that was amazing. I don't have a model for that here, but when my patients come in and they talk about, okay, I want to take this, I want to take that, I'm like, great, let's make sure that there are no side effects and interactions with their medications, because there can be. So we look at that. I look to make sure that, you know, that what they're taking, I have a good understanding of. I put it on their med list, and sometimes I have them speak to my pharmacist just to make sure that they're being monitored and followed. But, you know, it's important that people get a provider that they can trust. They can talk about the different types of things that they're taking so that we're all on the same page. And so, I definitely welcome people who follow Dr. Sebi and take the diet, but I also want to make sure people know that in and of itself, it's not enough.
What of his teachings like can you take, and then what something that like you should probably do something different?
So I have to be honest with you. I should probably familiarize myself a lot more. I know I read more about this probably about 10 years ago, and so I've lost touch with a lot of the teachings. I will say again that food is medicine. So food is medicine. I'm not trying to say that it's not. It's really important. It can definitely change, as I mentioned, our hormone balance. It can improve a lot of things with our vitamin levels. We were talking about before the break that people make changes in their diet, which reverses their diabetes, can improve even their blood pressure. That absolutely is the case. But we have not had food that treats infections. And it's for a variety of reasons. I mean, we have to have properties that actually can kill bacteria or kill a virus. And that's not usually in the materials that we're eating. So, you know, that's just something that we've seen. But it is important for good diet, clearly is important for good gut health and good lifestyle. So I completely condone that and support that. And again, I've had patients who do that. But, you know, in terms of looking through all the teachings, I think I'll probably have to familiarize myself a bit more. But it is not it's not a replacement for HIV medications or for any of the STDs that we just talked about.
As we're talking about comprehensive care, I wonder if we can talk a little bit about mental health and kind of the aftermath of discovering this news that, say, you were not attending for, and say, this was someone who didn't see themselves and as potentially attracting, say, HIV, and how do we go about doing the education, but also providing the mental health support that is necessary for their healing? And the second part to that is, what is the age range of patients you treat out of your clinic? And if you can talk a little bit on the younger patients and how they receive this news and what that looks like for them.
Yeah, and also too, like even thinking about that question, I was like, I know Shakira was talking about like what's the women who like kind of maybe experienced like mental or sexual abuse, like what is that correlation between that and like infectious rates?
So I think because I do this work with addiction and HIV, I have probably a special insight into some of this sometimes. And traditionally I will say our addiction treatment program has never, like if you smoked crack and you wanted help, you would call a detox and they'd be like, we don't do that, and then hang up on you, right? So like BMC has the first ever treatment clinic for crack cocaine and crystal meth. We have patients who got a new diagnosis, and the way that they coped with that is they used drugs because it made them feel better, because I felt so awful about myself. I was so lonely. I was so isolated. I was so depressed by this news. The one thing I knew would make me feel better was to do whatever, to use a drug, to drink. And so I think what we often see in the addiction clinic, right, is people who didn't get really good mental health care after a diagnosis like this, and they started to treat it themselves with a substance, right? And so part of when we start to treat the addiction is like, now I'm treating your addiction and all this other stuff is coming back, right? And the number of people who, I will say the event that you discussed, that the diagnosis of HIV is a traumatizing event. In the same way that any other physical assault or violence might be, patients can remember what they saw, felt, smelt, heard in the moments that we tell them that diagnosis. And so really being able to take this trauma-informed approach to how do I, because now you're back in the office. The last time you were in a doctor's office, you got this horrible news that changed your life, and how do we sort of manage that now? And so we do integrate behavioral health care in our outpatient clinic. So we have therapists that work with us. We have addiction treatment in the same practice as our primary care clinic, right? So you can get your treatment for crack cocaine with your primary care, with your pap smear, with your HIV treatment, all in one, like a one-stop shop, right? To make it easy for folks. We also try to make the clinic feel less clinic-y. Like, if that makes sense. But like, people don't want to come to like a space that feels super like, sterile and gross, you know what I mean? Like, you're like, right, like, it's just not fun. And so I think that's important. When we talk about age ranges, I'm a family medicine person, so I will see people from like pregnancy to a day old to like grandma with a walker, right? In terms of HIV care, I think probably the youngest person I've diagnosed was like 16. And I think it's always hard when it's a young person, because they have, and I think there's a difference between somebody who is perinatally acquires HIV and somebody who acquires HIV as an adolescent. And the populations look different. They need different things. And I think what we hear all the time is like these adolescents with HIV, and it's like, well, it's not a monolith. They all look different. And my 16-year-old guy who just got here from Brazil, who was sex working because he needed the money, is very different than the mom who was, late to care and delivered, and we didn't know, and we found out later. And so I think that's the other important thing to think about, is that the mental health needs of those populations are also very different.
Yeah, I would say, we have a lot more to go on to make the clinic a more welcoming space, as, Justin has mentioned, for family medicine, but we also have integrated behavioral health in our infectious disease clinic as well. In addition to that, I think we try to approach care as a triad in most cases. So it's the clinician, the nurse, and the case manager. And, you may not, maybe I'm not the right fit, but you might like the nurse. I usually like my nurse. She's kind of my boss. And then, and if that's not, if it, the case manager, so you got you got three people to choose from. And ideally, we all become family. But the case manager really, even though their role really is case management, not behavioral health, it really performs like an incredibly important service in terms of letting people know we are here for you in different capacities, in addition to behavioral health. In my pregnancy world, we've been a little bit, we've done things a little bit differently because we have less people. So we noticed during COVID that many of our patients were not coming in to get their prenatal care. They didn't want to be seen in a place where they might get infected. And so what we did is we took clinic out of the hospital for once a month. We are at a community-based site where people have much better access through bus lines. Parking is free. We have a food pantry located right on site there. It's cozy. We can all be there. They can see us. Their kids can run around. There are toys for their kids there. It just feels much more tight-knit. And we have a behavioral health person on our team. And so what we try to do is integrate that and not just have access to someone. What happens is that person goes into the room. They see the OB, they see the ID, that's me, they see the case manager, they see the pharmacist, they see the behavioral health person. And that's really important because we've seen a lot more people come through these really perilous routes. I will say, Justin was mentioning, like, talking to people about their faith traditions. It's really important, especially for people who've recently arrived, to figure out what are the supports here. It's not enough to be just us.
That's a great segue question I had. In a case where you have someone who faith-based sort of healing is very important to them, and they discover this news, kind of what we talked about earlier, and they are struggling to not only believe that they had it in the first place, but also that it came back because they believed that God had healed them. What does education and also what does care look like for that person?
I can answer. I think it's going to be different for everybody, and after answering this too, I want to talk about intimate partner violence too, because I think that's close to both of our hearts as well. So, and actually, this maybe not intimate partner violence, but gender-based violence is going to be part of this story. The way I respond to you. They gave you the medication. They told me it was going to be okay. They said everything was going to be fine. What she heard is everything was going to be fine, is everything is done with. Mm-hmm. And she had prayed, and she said, so to find out this was positive was a slap in the face.
Yeah, goddamn.
And, the fallout is still happening. But we've gotten to a much better point where we've emphasized to her that she is our patient. Culturally, in many cases, it's the couple that's the patient, and it's the man that's speaking, right, depending on where you're from. And so that's a culture shift, too, to try and figure out how we work around the edges and continue to give her care when her financial, all of her support, really, transportation, everything goes through him. And how can we do that? And that's a tricky part of it. We make it work. And I think, this is still new, but we're already starting to see that we're forming a relationship, and that over time she will be able to get through this. We have a therapist, they're engaged. The real answer is I don't know. It's going to be different for everybody. Mm-hmm. Usually, I promise my patients, usually it comes true within a year, that we were going to have very much different conversation, where HIV is like the fourth thing I mention. I might sometimes even forget to talk about their medications depending on what happens. And in mostly all cases, that does come true, that in a year from meeting that person and giving them the diagnosis, things are a lot different. But it's getting through that year.
Could I get Shakira, could you tell me from your perspective as a community engagement specialist, what's the correlation between domestic, was it domestic abuse partners and then STIs? And then I would like to hear the specialist talk about it.
First of all, the story that Cassandra just gave just took my breath away. As a domestic abuse advocate, we know firsthand that in intimate partner violence relationships or gender-based violence relationships, there's cases such as this where the individual is either raped on a consistent basis or forced to have sex and with their partner that they, either presume to be sleeping with other people or they just don't feel safe and comfortable. And then we have cases such as this where there's a diagnosis of an STI. And the opportunities for them to seek care is oftentimes either at a standstill or not happening at all because of the coercive control behaviors. And so when we talk about access to care and we talk about, people having firsthand knowledge, it's a matter of so many different pieces coming together. But I think the first thing is to make sure that we're individualizing these opportunities, right? Because as much as Justin and Dr. Cassandra has shared, we cannot look at this thing like a monolith because what came to mind for me with this story was the sexual abuse to prison pipeline. And Georgetown University did a study on this, and they dubbed it as this is the black girl story, because that's what we're told. That's what society has called this issue to be. And so when we think about, sexual abuse, we think about the black girl. And then we think about sex workers, we think about the black girls or the women of color who come from underserved or communities where there wasn't a man in a home or things of that nature. And those are all systemic issues that continue to be the catalyst for many people who are living with STIs that could be cured, right? Or maybe not as strenuous as gonorrhea or HIV as we talked about, but it's the fact of at an early age not being exposed to this information. And then there's the huge differences between perinatal and adolescent diagnoses, right? Because the reality of it is oftentimes when it's perinatal, some families grow up with this understanding of this happened to us, we're going to combat this as a family, we're going to do these things, we're going to follow these steps. But that usually comes from families who already have a healthy relationship with healthcare. When you talk about families who go through systems such as, shelter or homelessness, we got another problem, right? Because the majority in the state of Massachusetts, in the city of Boston, if we look at the statistics in reference to homeless students, that we can already correlate what issues might come with that, right? What other implications are in those circumstances? And STIs are on the rise of that. We've seen this for a very long time. And so for me, as an educator and as a community engagement specialist, I'm always thinking about the people first. So when we put people in positions where we're giving them firsthand knowledge and allowing them to be a part of this, participation of making sure they're understanding what this treatment plan can look like, we can't do that without having systems in place. And so Dr. Cassandra and Justin being able to provide this information and really make this thing a holistic approach in the sense of we see you as a person first. And that's what our goal is at MACL, is to make sure that in all of our efforts, and I'm becoming so teary-eyed right now, but in all of our efforts, we're trying to make sure that we are being transparent from the start, that we're giving people information that they can stomach, and then resources that they can follow and they have access to. And I don't know why I'm super emotional, but whenever it comes to subjects such as this, where people like us don't have access to these type of conversations, it changes the narrative for some people. For adolescents who are going through STIs or recurrent issues of intimate partner violence, hearing these conversations and knowing that we see them, that changes the narrative for so many people. And so, shameless plug, but shout out to MACL for making this happen, and thank you guys for trusting us to bring these type of communications and conversations to the community, because this is not a thing that happens often. And thank you to the NIH for allowing us to have this free will, if you will, to really get to know what the community wants to hear and talk about, and really making it come to their level of understanding. This is not the traditional where you would meet Dr. Cassandra and Justin. But the reality of what we're trying to do here is to bring the people who are doing the work in the hospitals from behind those desks and into the community. And we couldn't do that without people such as Dr. Cassandra, Dr. Zai, who was here talking about COVID, and Justin, who are adamant leaders in our community. And so for us, for myself and Jasmine as community engagement specialists, and I know this is a drawn out answer, but it's important. Our goal is to make sure that the people who need the information most have access to it, whether they're joining us from a Zoom at their house where they feel comfortable, or they're meeting us in community. And so we can't talk about intervention without being intentional about where we're going with this information.
And I will just say, so I actually sit on the board of directors for Casa Mirna. And so I totally agree with everything you've said. But I think when we talk about intimate partner violence, and we talk about communities of color and women of color in particular, one of the things I want to go back to the PrEP. I'm going to do like a recall, like a comedian here. But PrEP is such a game changer to give people autonomous ability over their health care.
What is PrEP? I'm sorry, I don't even know what
PrEP
that is.
is pre-exposure prophylaxis for HIV. So you take either a pill every day so you don't get HIV, or now we have an injectable that you can get every other month so you don't get HIV, right? And we also have access to reproductive health care, right? Do you want an IUD? Do you want an Nexplanon? Do you need an abortion? Right? And those are all things that we can do out of family medicine and out of Boston Medical Center and out of healthcare systems. And I think one of the really important things that needs to happen is more conversations like this where we leave the hospital, right? Part of the reason I work with Casa Mirna, part of the reason why I work with these other organizations is they need to know, like, you can call me. Like, reach out. We want help, right? Like, that's why we're here. And so if stuff is going on and, like, the one safe space is that doctor's office room where I can kick out your partner and we can have a conversation, let's do it, right? And if you're like, I can't take pills because then they're going to know I'm having sex with other people, or he's going to know I'm worried about him giving me something, let's do the shot. You come see me every 2 months. I'll give you a little shot. Good to go. Right? You don't have to take pills. No one's going to know you're on that. And those are like game changers for healthcare people to be able to offer folks, and having those real conversations about what form of PrEP works for you, what form of reproductive healthcare works for you, right? If you're like, I'm a Plan B girl, great, let's do it. Right? If you're like, nah, I like the IUD because then I know it's there. I can feel it. That's what I want. Let's do it. And I think really having that big conversation about all of it together is important.
I would also just mention that many hospitals, maybe not all healthcare centers, but many hospitals also have a domestic violence program. So the other thing that we sometimes come into contact with, and we're also learning as clinicians, is that you disclosing to us doesn't mean that we need to start to fix it. And you don't want that. You may not want that anyway. And so we're trying to become a little bit more sophisticated in terms of how we speak. Okay, what services are you interested in? Our DV programs are the specialists, and they have been wonderful partners. They've worked with our program. We have these safety cards that we give to our pregnant people when they come in now. It's not saying, we're not screening, but we're just giving people this information. They can choose to keep it. They can choose to share it with a friend who might need it. But it has all the resources there. I would also say, just in addition to these excellent points, we know that people living with HIV are at higher risk for intimate partner violence, and people who are experiencing intimate
did not
partner
know that.
violence
I didn't know that.
have a higher risk of having HIV as well.
Is it any reason why?
Right.
Could I just ask why?
What was just being discussed.
Oh, yeah.
And so a lot of times, if I'm known to have a boyfriend, but I have a girlfriend, she's abusive, I'm not going to report it or speak out about it because I'm afraid of what the outcomes can be. And it could be for a male or female, but I know in the LGBTQ community, the prevalence of violence in same-sex relationships is extremely high. And even worse when the individual decides, I'm going to leave, and they voice that, especially in young people. Earlier, Cassandra said that the CDC recommends between 13 and 64 to have an HIV test in. Well, in intimate partner violence relationships in the LGBTQ community, when it comes to mortality rates, this community has a higher rate when it comes to the breakup. And it's usually at the height of the person saying, I'm going to leave, and that person responds in that manner. We see a lot more mortality rates within that population, but when we look at numbers, it's neck and neck between same-sex relationships and heterosexual relationships. So there really isn't a huge difference. But in terms of the reports of it, the prevalence of it, there is a significant difference. Because for LGBTQ communities who identify as being someone who is being harmed by their partner, that's usually the way to get help, right? And to feel safe. In terms of a heterosexual relationship, is looked at as that's a problem between the two of them. And they don't have as much stipulations or steps they have to take when it comes to getting a formal order of support, like a legal protection. But when we come to the LGBTQ community, it's like, oh, they're just friends. And so it hasn't been recognized. The legal system is getting a little bit better, but we are still seeing the issues with that. And then I won't even talk about when it comes to seeking shelter. Like, you're living with your partner in a same-sex relationship and intimate partner violence happens. Where do you go?
Yeah.
Right? And so there's so many steps to that. But
Well, what are the resources for that?
so Casa Marina is a huge resource for that. There's SafeLink that folks can call if they want to make some anonymous, conversations. I would start with SafeLink and then start looking at your community-based organizations that you trust. There's so many to look at, but right now, that's what I would say.
And the Network Lared is another one here in Boston, specifically for LGBTQ communities that face this kind of intimate partner violence. And I think Cassandra talked about, and you both talked about, I totally agree with everything you've said about sort of the difference in rates of HIV, the rates of violence. And I think it all goes back to this change in power dynamics. Whenever there's a power imbalance, because you believe you are less than because of an HIV status, you believe you're less than because you're gay, you believe you're less than because you're a woman, that is the opportunity for violence to happen.
That's called coercive control.
Right. And so I think that's understanding
sense,
that
actually.
power imbalance is really what drives the violence, and that those things are what drive risk, right? For things like STI acquisition, for unwanted pregnancies, for all those kinds of things.
That makes sense. Jonathan, do you have anything to ask before we start?
No, I don't want to make anything up.
I want to ask one of our final questions. What could compel community members to come out and actually get tested? Is it a drive? Is it an event? Is it food? Is it conversations like this? Specifically from your perspective, Shakira, what do you think could compel the community members to come out and actually get tested?
Or even destigmatizing this conversation?
First of all, that's a question that we want to put in the chat, and we want to hear back from community members. We can't do stuff like this without knowing what the community wants. And so if the community will tell us how they want to hear this information, then we can tailor it, right? We can make sure we have the right people in place. But there are, I believe it's in the chat, the number for the STI clinic. And then Justin and Cassandra have proven that they're reachable. And so if folks reach out to us at MASEAL at bmc.org, we can make those connections for linkage to care. But we are in the works of looking at what does that look like? Do we have a health fair? Do we continue to have these lunch and learn sessions where we're doing these pop-up, testings and things of that nature? But we don't want to tell the community, from a community engagement perspective, what they need. We want the community to share that information. And so those are one of the things that we're hoping to take away and having these series of conversations is how is the community receiving this information, and what are they asking for us to do in return? What do they want us to do with this? And then the questions that are being asked, shout out to Dr. Sabrina, who will be answering any post questions regarding the sexual health conversation. And then super shout out to Javier, who is another STI clinician, who is also going to give us some more information post show so that folks can be aware. And if you don't feel comfortable with Cassandra, you don't feel comfortable with Justin, we have some more people at Boston Medical Center that you can be connected to. And so in terms of what do we do with this, we're relying on the community for that.
Exactly. So wait. So if there's any questions you guys have that we did not tackle, throw them in, and we're going to give them to another doctor to answer those questions.
I think I completely agree. I would like the community to tell us what would be helpful, but I also think it's helpful for the community to know what the options are. Right. So in addition to, having a health fair or coming to a family medicine or a primary care appointment or going to an STD clinic, there also is self-testing that is available for things like HIV, right? With the OraQuick.
I did not know that.
Yeah,
that's great.
It is. It's commercially available, right? There are ways that you can do self-testing for STIs, albeit, it has to get run through a lab, but with minimal interface with a human being. So it's helpful to know for people to know what might exist and how that gets built in a way that feels like people can legitimately access that.
And I think just really, I want to echo everything you've both said and really raise up the point of, we have an opportunity with things like pre-exposure prophylaxis for HIV, that if you're on PrEP, whether it's pills, whether it's episodic PrEP, whether it's injectable PrEP, where we're going to build in the STI testing, and we'll build in the family planning and we'll build in those things. And so it may be a great opportunity. We're working right now to work on this like women's wellness group in family medicine. We're going to come in, we'll do the aromatherapy, we'll do Reiki, and if you want injectable prep, we'll do it today.
Oh wow.
Right? So
Yeah.
change the conversation about prep as a wellness tool rather than like, because we all want to have sex, right? Right? Like we all want to have good sex. And so like, can we have a conversation where this is part of a healthy sexual discussion for folks?
I love that you say that, Justin, too, because for young people who are trying to figure out their bodies and figure out what's happening and what's all these changes, we do a healthy relationships conversation outside of this role, and oftentimes parents are like, "What? You're gonna talk to my kid about having sex?" And so that stigma of it's not safe, it's not fun, and you wait till you're an adult. But a lot of people don't have that option. And so it takes me back to the young folks who lose their virginity in sexuality to harm or sexual abuse, and then also to young people who are trained, and brought up or to do this thing, right? And so there's so many different ways that we can look at this. But when I think about young people and we think about the natural autonomy of the body and folks wanting to feel what they feel and understanding what these feelings are, we have to really make it normal to have these type of conversations with young people. And so for younger people, it's not using your kitty or cute words to describe body parts, because when we look at sexual abuse, it's hard to put that story to pieces when we're talking about a cookie's hurting and things. So we need to be honest. And so I think having these hard, real, transparent conversations at home needs to happen. And I think from an educator perspective, some parents put a lot of pressure on educators, right? In terms of the school's not offering sexual health. So if the school's not offering sexual health, then have that conversation at home.
So I completely agree with you. I've just been thinking about, like, when we talk about how do you do sexual education in schools for young people, I agree. The parents need education as well in normalizing this so that they can. I remember my mom had a conversation, again, coming from a very super Catholic upbringing. My mom was like, at age 15, no less, she was like, have they spoken to you? Not have they given you the talk. Not have you had education? She said, have they spoken to you? We had, it was it was a comedy skit for 15 minutes. Have they spoken to me about what? And then finally I understood. And of course, I was like, oh, sure. Whether it was yes or no, the answer was going to be yes. So I completely agree. Like, it needs to, people need to have honest conversations, maybe even with their pediatricians. Like, how are you going to broach this subject?
Wow. Thank you guys for all this super amazing, valuable information. Is there anything else from a community perspective and from a medical perspective that people should know?
Or even if you just want to recap those sources.
So I will say my big thing is I was an ER nurse for a long time. I was an HIV nurse for a long time. I do addiction now. The only thing I'm afraid of is the unknown. Right? Come in, come get tested, have a conversation with us. I can help. Right? Like, even if it's not fixing, even if I can't cure it, even if I can't, there's stuff we can do to help. And I think that that's the really important thing. And I think a lot of communities, particularly BIPOC communities, don't view the healthcare system as helping anymore. And we need to change that narrative. That I am here to help, and you have to tell me what that looks like for you, and how do I meet that need. So that's my big takeaway from today. If for people listening and watching, what is it we can do to help? Let us know, and we're here to try and meet that need.
And do you need a primary care person, or can you just walk into any clinic?
That's a great question, and it's really hard. So in family medicine, we actually have a family planning nurse who can see patients without having a primary care. Usually, we try to link you to a primary care. The STD clinic, you also don't need a primary care. You can just go. And then oftentimes what happens from the STD clinic is they link you to a primary care like me. They're like, hey, you should go see Justin. He does this. So really trying to think about where should you be linked to. And there's some people who I'm not the primary care for you.
Yeah.
Right? They're like, I don't want to talk to him. Right? It's not going to be fun. And so that's fine. Maybe you need a Dr. Cassandra Pierre, right? Maybe you need somebody who looks different, sounds different, speaks a different language. And we try to meet those needs as best we can.
In the Mattapan, Dorchester, Roxbury area, where's the places to go if you want to get tested?
Yeah, so really it should be anywhere. But Mattapan Community Health Center, Codman Square Health Center, Dorchester House. Upham's Clinic, thank you.
MAPS, which is the Massachusetts Alliance of Portuguese Speakers, has free testing.
There are many more.
So we're going to get in trouble for the people
I know,
who forgot.
right? So
that's really why I'm having a nervous breakdown
I'm
right
sorry.
Just call Boston Medical Center.
You know what I would say is
Whittier Street.
Whittier Street, thank you,
See,
thank you.
that's where
I know,
we would have
right?
been in trouble.
So what I was going to say too was just going to be an add-on to this, really, which was sometimes finding the right doctor is like dating, or
Yes.
the right clinician is like dating, and that really is the takeaway point. It is important that you find. It is imperative that you find someone who you feel reflects your values, who takes interest in you as a human being, who is not going to rush you out the door. I mean, we do have time limits, but is going to make you feel seen and heard, and address the things that you need to be done. So wherever you get your care, it's important to seek such a person out. Most health centers that you go to should have this available to you. If you feel like your provider may not be literate in this or comfortable, that may be another thing. They may just not feel comfortable talking about sexual health. You are not locked in to one physician. You can find someone that will give you full comprehensive care. So yes, you're welcome to walk into the STD clinic or family planning clinic, but we're always going to recommend that we're always going to see it as a gateway to getting to your person. And they're out there.
Shakira, you have any
First of all, shout out to Curtis Santos, one of the founders of the Boston Urban Les by Gay Foundation, for being in the building with us today. I think when we talk about sexual health and we talk about health and care, oftentimes we think about go to the doctor, but for so many people it's going to community-based organizations that they feel is part of their family. So maybe it's the YMCA, or maybe it's maybe it's MPDC, maybe it's a program such as the Boston Urban Les by Gay. So finding your community and where you feel heard and seen and supported, and finding that person or maybe those people. I always tell people, if you don't have a mentor, we have a problem. And so maybe it's somebody that you trust that you can talk to, that can help to streamline you to getting to these resources. Because for some people, when you tell somebody to go to the doctor and they know they have some underlying issues, it's almost like a trigger word. And so we just got to be careful. So I always say, make sure that you are making suggestions or recommendations from a safe place, but know your person, know the person that you're talking to, because we want to make sure they're receiving it and then that they're going to, use those recommendations. But from a community engagement specialist perspective, I can speak for myself and Jasmine when we say that doing this work and hearing what community members want to talk about and learn and be a part of is very important. And so, again, we are thankful for the opportunity to have Dr. Cassandra and Justin on the couch with us, and also Mr. John Mende for joining us as a community member. A huge part of our role as specialists is we have to report out what the impacts of these type of incidences look like, right, or events look like. And so having you from the community to speak and share, whether you listen more than you talk is totally fine. But the reality of it is we were able to bridge this gap and show this connection of this is what it's supposed to look like when we talk about healthcare. We can't have the separation of there's a doctor and then there's the patient, or there's a hospital and then there's a community over there, or we can't like Dr. Cassandra said. And so we're grateful to have had you on the stage with us today, on the couch, as Show and Tell Boston says, to show that, the connection between us and the community is possible, and it's safe, right? You feel safe up here? Oh, yeah. Oh, okay. We ain't doing nothing wrong, right? I want to make sure we.
Well, just real quick, add and say that when we talk about comprehensive care, this is what it should look like.
Care. That's right.
It should look like that. I want to be able to say to people that, hey, when you go see a doctor, they want to know everything about you. They want to know, where the last person you were with, what that looked like, but also where to send you and how that might look like for you to get the kind of care that you need. It's like we alluded to earlier, it's not just the diet that you're putting into your body, but it's also the exercise. It's also the regular visits to your primary care. And if you don't have one, definitely get a primary care doctor, because a lot of preventive measures can be put that way so that they can get ahead of any kind of issues that may arise later on. And you never know, anyway, I'll just kind of pause it right there in saying that, yeah, definitely get a primary care doctor. I know personally myself, I'm a behavioral health counselor, but I've also dealt with my own issues. And so going into a primary care doctor who was able to detect you're going through something that no one else was able to detect. And all of a sudden I was getting the services that I needed. Right. And so, go ahead and see someone. And if you don't get along with them, go see someone else, as it's already been alluded to,
100%.
because your health comes first. And it's the most important asset that you have.
And I will say that I just got out of a monogamous relationship, and like she told me she got checked, but I was like, no, I should get checked too. This conversation made me like, let me just get this checked out.
Go on,
You know
make
what I
that
mean?
appointment now.
I'll go to Mattapan Clinic. He said, okay, let's go.
Okay, that appointment.
Let's go.
I'm gonna call you tomorrow. Make sure you made the
You
appointment.
know what I mean? Mom, am I clean? And if not, we'll figure it out.
That's right. That's right. All right, family. Thank you guys so much for being here.
Thank you for having us.
You are welcome.
Shane, Tata, and Cricket.
You are
We
so
appreciate it.
welcome. This wraps up our conversation about sexual health in our community
Coming
with
up
our
next.
teams, Boston Mass Seal and Boston Medical Center. We out, baby.